Imagine students, this is your classroom and there are 100 students in classroom, and this is door of your classroom. It normally opens full, but now due to any reason there is jam of this door and students are not going outside because it's only 10% open, this door. So there would be chaos in your classroom. Same happen in case of aortic stenosis. Aortic mean aortic wall and stenosis mean narrowing. So normally this is left atrium, this is left ventricle, this is aorta. So this wall is aortic wall, and if it is narrowed, this is known as aortic stenosis. Progressive stiffening of aortic wall lead to the narrowing of aortic wall orifice. Orifice mean this small hole. Ultimately lead to the obstruction of left ventricular outflow. So left ventricle blood will not go into the aorta because this aorta has been, wall has been narrowed down. Pathophysiology, lipid deposition or hemodynamic stress. There would be lipid deposition on this wall, or there could be stress on this wall which lead to the endothelial injury. So this wall is injured. There would be inflammation in this wall, which inflammation ultimately lead to the fibrotic stiffening with calcification. There would be fibrosis but with calcification, ultimately lead to the decreased mobility and restrict wall opening. So he's saying that there would be any lipid deposition or any stress lead to the injury lead to the inflammation, and this inflammation lead to the fibrosis. And this fibrosis, if there would be fibrosis, normally wall open, now it's not opening, there would be restriction of blood flow from left ventricle into the aorta. So left ventricle generate increased pressure. Now left ventricle is saying that it is jammed, but I have to work hard so that blood will go into the body. So there would be more forceful contraction, so there would be stress on this muscle. Left ventricle generate increased pressure. There would be concentric left ventricular hypertrophy, which lead to the decreased compliance. Compliance mean its size has been decreased. In this diagram, normally it was left atrium, left ventricle, and normally the wall is good. Now if wall is stenosed, like it is stiffened, so it's not opening, left ventricle has to work hard, so there would be increase in size of this wall. This is called concentric left ventricular hypertrophy. But now there is less compliance. Compliance mean its ability to hold blood. Normally it was big and now it is decreased, so this is its compliance has been decreased. Now we'll study etiologies. What are the causes why this wall stiffened, why this stiffening, and why there would be decrease in its size. First cause is age-related degenerative calcification. A patient has been aged, like more than 70 its age. The risk factor include diabetes mellitus, hypertension, smoker. Patient is smoker or diabetic or having diabetes and is also aged more. So we know that as patient grow old, there would be more chances of calcification and fibrosis. It is most common in developed countries like America, Europe. Second cause is degenerative calcification of congenitally abnormal wall. Now congenital abnormal wall. Normal wall is having 3 cusps, 1 cusp, 2 cusp and 3 cusp. But if there is congenital abnormality, there would be no fusion of these wall, so there will be just 2 cusp, 1 and 2. Now it is more prone to stress and having more chances that it would be calcified. So it is a second cause. And the third cause is rheumatic heart disease. In rheumatic heart disease, there would be autoantibodies. Normally it affects the mitral wall. Most mitral wall affect, but can also cause aortic stenosis. Most common in developing countries. So in developed countries, most common cause is age-related degenerative calcification, but in developing countries it is rheumatic heart disease. Now pathology. So on histopathology, when you see this wall on microscope, what you will find? You will find histologically infiltration of inflammatory cell. As we have studied, there would be inflammation. So in inflammation, there would be specific cells. Which cells? Macrophages, lymphocyte, plus there could be lipid deposition fibrin deposition with calcium. All this we can find histologically. Now clinical presentation, how patient will present to you in clinic that doctor sahab what happened to me, है ना? This is clinical presentation. If in case of mild, moderate and asymptomatic, there would be no symptom, but it is severe. If there is severe aortic stenosis, then symptom would appear. So in case of severe aortic stenosis, what are the symptoms? The first is exertional dyspnea. It is the first symptom because left ventricular outflow has obstructed. Left ventricle is not pumping the blood into the body. Because look at this. This is left atrium. This is left ventricle, and this is post aorta. This is aortic wall. Now less blood is going outside, so cardiac output is decreased. Low blood is going into the body. It would cause exertional dyspnea. When patient says, when I run or when I do some work, I feel shortness of breath. Second symptom is exertional angina. Now, as we know, the muscle mass is increase of the heart wall. So there more muscle, more its need of oxygen, and less blood is going out. When this increased muscle mass have low oxygen, it would start dying. Now second symptom is exertional angina. Exertional mean when patient do exercise, when he walks, when he climb upstairs, he feel angina, chest pain. Why? Because increased demand of oxygen. Muscle has increased. Now size of muscle has increased, concentric hypertrophy. Now this muscle need more oxygen, but there is stenosis, less oxygen is coming into this muscle. So it start necrotizing and cause exertional angina, chest pain. Next is exertional presyncope. Presyncope mean lightheadedness. No less oxygen is going to the brain, less cerebral perfusion. This was cause exertional presyncope. And the last symptom, heart failure. We know the symptom of heart failure: pulmonary edema, jugular venous distension, left extremity edema. In case of severe aortic stenosis, when it is untreated. So one thing you have to remember, all these symptoms are exertional. When patient do exertion, then it will feel this symptom. Now physical examination, the most important thing. When you examine the patient, when you put on your stethoscope and auscultate his chest, you will find crescendo, decrescendo systolic murmur. Murmur is sound. It happened during systole, not diastole. And this is its specific characteristic, crescendo, decrescendo. It is sound. You will find this sound on right upper sternal border. Suppose if this is sternum, you will find on right side upper sternal border on this side. When you auscultate this side, right upper sternal border, this is aortic area, you will find this murmur. S2 would be soft. S2 happen when there is closure of pulmonary wall as well as aortic wall. But now aortic wall has stiff, it's not completely closing. So S2 would be soft. S4 may present. Why? Because it's now concentric hypertrophy. So when blood came from left atrium into the left ventricle, it strike this wall. So S4 is produced. Diminished and delayed pulses. Narrow pulse pressure. Pulse pressure would be narrowed. This is called pulsus parus et tardus. ET at TARDUS tardus. On ECG, when you do the ECG, you will find left ventricular hypertrophy. We have studied there would be concentric hypertrophy. On chest X-ray, you will find aortic wall calcification plus left atrial enlargement. Why left atrial enlargement? Now look at this. Now its compliance has been, its size has been decreased. So blood is not coming into the left atrium, from left atrium into the left ventricle, because its size is small. So there would be pressure in left atrium and left atrium is enlarged. And on chest X-ray, you will find left atrial enlargement. Diagnosis. How will you diagnose patient? Diagnosis is based on clinical presentation. All the history of the patient plus physical examination, you have done this. Patient presented to you that I feel shortness of breath. You do physical examination, you will find this murmur, all these symptoms. So your doubt is that maybe patient is having aortic stenosis. So you confirm the diagnosis on the basis of echocardiography. Okay, so clinical presentation mean history plus physical examination plus echocardiography will confirm the diagnosis. On echo you will find elevated aortic jet velocity. What is this? Normally when left ventricle pump, blood go into the aorta. Normally this wall is not so close, it is like this, and when it is stiffed, the size of this orifice is small. So when blood pass through this small area, it pass with more speed. So this speed has been increased. Elevated aortic jet velocity, how much? More than 4 meters per second. Look at this. Elevated transvalvular pressure gradient. Now the pressure gradient between aorta and left ventricle is increased, and reduce wall orifice cross section area. This cross section area is also small, less than 1 centimeter square. How will you manage the patient? Management. For in case of mild to moderate, you will just tell patient periodic clinical surveillance. Please come to my clinic after every 1 year. But if there is severe symptomatic aortic stenosis, there are two chances. Either you manage the patient medically, medical management, or it is surgical management. Now medical management is limited, but surgical management is definitive treatment. In medical management, there would be negative chronotropic agents like beta blocker, non-dihydropyridine calcium channel blocker. What these do? It decreases heart rate. Now when heart rate is decreased, so there are less chances of exertional angina. As well as you will give diuretics like furosemide if there is pulmonary edema, venodilator like nitrates, and mixed vasodilator. Now surgical treatment is definitive treatment, and you will do aortic wall replacement. You will replace this wall with new one because this wall has been stenosis and it's not working now, so you will replace it. Now replacement could be mechanical or bioprosthetic. Complication. What could be the complication of the patient if you does not treated this patient? First complication is heart failure due to contractile failure. Second is atrial fibrillation. Why? Because left atrial is enlarged. When there is enlargement of left atrium, it can cause atrial fibrillation. Obstructive shock. Obstructive shock, there is obstruction, blood cannot go out of left ventricle into the aorta because the wall has been stenosed. So this can cause obstructive shock or sudden cardiac death. These are the complications of the patient.